And Perth are probably in the unusual position of having more people there than we have here. But anyway, welcome, people in Perth. I'm John Irving. I'm one of the interventional cardiologists. Tom recruited me in the depths of winter at the Cullen Award, not realising there was going to be a beautiful day and everybody would be outside in the sunshine. The Cullen Award was sponsored by the College of Physicians in honour of William Cullen, and it was a competition between various medical specialties. And they originally planned a sort of a boast-off between the various different consultants, taking 10 minutes to talk about how wonderful their specialty was. But that prospect was too nauseating, and in the end the talk was given by somebody else, and it was probably better. So I've got 45 minutes to talk to you today a little bit about what's been happening in interventional cardiology. And everybody working in Scotland received the report from Catherine Calderwood about realistic medicine, which has generated a lot of interest on social media. And it's certainly an interesting document, and it's very interesting, particularly when one's involved in a specialty that certainly in other parts of the world there's a perception that cardiology patients are over-investigated and over-treated. There's certainly a lot of variation in treatment rates. We're expensive. Do we work collaboratively with patients? There's a lot of interesting challenges here for an interventional cardiologist. So I'm going to talk about three aspects of modern practice and look at them all through the prism of these sort of questions. And I'll be interested to see whether you think that we're realistic or not. The first thing I would say that the hugely varied procedural rates internationally depend chiefly on very high rates of work done in America or Germany, where everything's organised on a fee-for-service basis. So you build the facilities with an expected patient flow, so it becomes very difficult not to do a procedure if the income stream from these patients is expected to maintain facilities and salaries. And so they do twice as many angioplasties or more in other parts of the world. But I think the way they organise their finance has a lot to do with it. So I'm not going to talk about that any more than that. You see this quote from time to time: there is no prognostic benefit from elective PCI, and that's based on randomised trials of patients with single vessel coronary disease generally, I'll show you that statement is probably incorrect. Value for money, I'll show you a little bit about that. Shared decision making is extremely difficult if somebody is coming in with an acute myocardial infarction. And I think it's also difficult in clinic. I think most patients coming to the cardiology clinics are absolutely terrified that we're going to tell them that they're going to drop down dead in the next few weeks. And I try to remain conscious of the fact that the patients are perhaps not at their best, not at their most assertive, and at least offer them the prospect of a discussion rather than a paternalistic decision-making process. Managing risk, I like to think we're quite good at that, and encouraging innovation. Yeah. So this talk will talk a lot about what's changed in the 10 years since I've been a consultant. So, realistic interventional cardiology. We do primary angioplasty for acute myocardial infarction. And I'll talk a little bit about the data that supports that with a case history. I'll talk a little bit about whether people with complex coronary disease should have multivessel angioplasty or coronary bypass graft surgery, and the data's changed in the last 6 months. And I'll talk a little bit about PCI for chronic total occlusions, which is a personal interest of mine, and I'll try not to go on too long about it. So, case report first of all. This is an ECG very similar to the ECG of an 89-year-old lady who presented to us a couple of years ago. And she was in pain, and ECG was telemetered in, so we knew she was coming in. We were able to read a bit about her, so she was living independently, and she'd been seen in the rapid access chest pain clinic about 6 weeks prior to the acute myocardial infarction. This was the first picture that we took. It probably won't transmit very well to Perth, but here's a guide catheter inserted from the radial artery to minimise the risk of bleeding. She's got severe disease that you'll see more clearly perhaps in the next picture. She's also got a blocked right coronary artery, so she's got severe ischemia. There's very little blood getting to her heart. And shortly after this picture was taken, before we took another one, she had a cardiac arrest. And we resuscitated her and put in a temporary pacing wire because she'd had profound bradycardia. This is a different angle. There's a wee bit of overlap here, but if you look at this bit here, just away from the catheter, you see that it's very narrow there in the circumflex. It's extremely narrow at the ostium of the LAD, and the right coronary artery is blocked. So she's profoundly ischemic and critically ill. This shows the ostium of the LAD a bit better and the collateral filling of the right coronary artery. And I managed to get some wires down and balloons down, but despite doing a very short inflation in both vessels, she had another cardiac arrest, and we had a brief attempt, but she died. So was that a realistic thing to do? I'll come back to it after I've shown you some of the data. So this is why we do angioplasty rather than giving thrombolysis. This is an analysis of the data. 8,000 patients randomized in 23 trials internationally, half of them getting thrombolysis, half of them getting angioplasty, with various styles of these interventions. And when you put it all together, immediate angioplasty is better than thrombolysis because fewer people die in the short term, and also again in the long term. Fewer people have strokes, particularly hemorrhagic strokes, which was a very distressing complication of therapy. And when you measured it this way, there's reduced pain, which they call recurrent ischemia. And actually, the thing the reason that it's most compelling about treating frail elderly patients with acute myocardial infarction is that actually it relieves their pain straight away. So there have been a few frail patients, you think, should we do this? And 20 minutes later they're sitting up in coronary care, drinking a cup of coffee and having a sandwich. And when we used to use thrombolysis, they'd still be really, really sore. You could kind of make them comfortable, but they'd be nauseated with the opiates. They'd still be sick. Whereas if you can stent open an occlusion or profound narrowing, people feel well rapidly. And that's really the compelling reason to treat frail people. Those data were translated by sign into the sort of table with numbers needed to treat, which are very small, which we could translate into patients treated in Tayside having reduced numbers of important complications of MI. This is with a death rate of about 8% with thrombolysis. In the real world, if you look at the MINAP, the National Infarct Angioplasty Project in England that has been collecting data on heart attacks for many years, they showed that the inpatient mortality was a bit higher than in the trials, as you would expect. I've got a medical student doing a project at the moment looking at outcomes, and our in-hospital outcomes are about death rates about 5%. So we can achieve the trial results for angioplasty, and it's slightly better treatment than real world. it's slightly more effective than the trial data would suggest, because real-world patients do worse than trial patients. The reason that we treat people in a hurry is illustrated quite nicely by this slide. So if you look at low-risk patients, their survival out to 10 years after angioplasty is pretty good. It doesn't really matter what the delays are in low-risk patients. If you look at high-risk patients, the people who have short delays to treatment, and this was door of the institution to balloon in the cath lab, short delays do best, long delays do worse. The difference between short and long is about an hour and a half, and then the lines are kind of parallel. So perhaps if these patients had been treated more quickly, then they would have actually followed this survival curve. High-risk patients were defined by having heart failure, more than 70, or anterior infarction, but were more than half of the cohort. So speed of treatment is an essential part of primary angioplasty, and influences the cost effectiveness as well. So when it was introduced in the pilots, they costed everything in the UK, and the cost per QALY is £4,500, which is very cost effective. And that's if the delay between when you could potentially get thrombolysis or angioplasty would be 60 minutes. But if there's shorter delays, that people come straight to the cath lab, primary angioplasty is more cost effective. But if you're admitted to a second hospital, and it always takes a long time to then get another ambulance, get a transfer, and the delay was 100 minutes, then thrombolysis was more effective and cheaper. It compares very well to other very effective treatments. Trastuzumab has revolutionized treatment for some patients with breast cancer, but is expensive. Cheaper interventions are still very cost effective, but less so than primary angioplasty. And even if you do something very cheap, requiring a can of iron brew and a couple of glucose assays, screening for gestational diabetes, it's still not as cost effective, because you've got to do it to a lot more people. And the primary angioplasty was set up in Scotland about 7 years ago, and covers 90% of the population of Scotland, with acceptable transfer times to get effective primary angioplasty. The UK has done very well in terms of collecting data to show how effective the processes are. So we talked a little bit about door to balloon and how important it is that you do it quickly. This is a funnel plot, and you can see where your institution is in relation to other institutions. So the Golden Jubilee like to share this data on a regular basis, because they're great, and they are great. However, the only way that you can get into the Golden Jubilee for primary angioplasty is to be diagnosed somewhere else. So they always know that you're coming if you're having a heart attack. They don't have an A&E on site, and similarly the Freeman in Newcastle don't have an A&E on site. So while it shows that they're good at what they do, we struggle to achieve the same door-to-balloon times, because 10% of our patients or 15% of our patients self-present. We do better at call-to-balloon times. So this was the graph that I gave to the Cullen for the Cullen Award to show how marvellous we are. So if you look at what proportion of call-to-balloon times can be achieved in less than 150 minutes, the patient calling for help to getting picked up by the paramedics, diagnosed, in the ambulance, transferred into the hospital, onto the cath lab table, vascular access, catheter to the artery, balloon in the artery. Can you do it all in less than 150 minutes, which was the target? And again, you can compare yourself, and we seem to do extremely well, which is fantastic. But I had a revelation a couple of weeks ago that we are always recording the time that the ambulance get the call from the EPRF, the electronic patient record form, because that comes in, and that's where we've always recorded it. And I had a look at Portal, and it may be that some patients phone NHS 24 or NHS Direct, and there's sometimes a bit of faffing around, and it may be that other hospitals that appear not to be doing so well are actually recording a different thing. there are very high quality data collected in the UK at the moment, but actually with austerity, the budgets to collect these data and provide analyses are drying up. It's becoming extremely difficult to collect the data. And it's not like clinical trial data where you know that everything's been collected in exactly the same way and you've got people employed to come round, go through every single point of data, make sure it's collected consistently. So I don't know whether we're flattered by this or not, and it's actually, on a practical basis, difficult to find out. But it certainly doesn't look as though there's a problem with the service, and that's our impression. The other bit of data that may no longer be available is individual consultant operator outcomes. So this is my slide. So my predicted percentage of cases free from in-hospital MACE was 96.95, and I did slightly better than predicted. Still getting some complications because that's inevitable. But it may be that these data will no longer be published because we, as a nation, decide that we can't afford this level of bureaucracy. Specific data on nonagenarians. This is a paper published recently from a variety of 5 big international high-volume centres. So that's as for Zaman's professor in Newcastle, looking at 145 nonagenarians, 21% presented with cardiogenic shock. So these are sick patients, and a lot of them die of their myocardial infarction. But actually, this sort of survival rate, this sort of curve is probably similar to most nonagenarians. And the data is that if you survive the crisis, then actually you generally have pretty good quality of life. So who was being more realistic? Was it the doctor at the chest pain service who doubled the amlodipine, which might help angina? The patient had to give up playing tennis at the age of 89 because of her angina. And I don't know what discussion was had, and it's very easy to frame discussions the way that you want. But if that patient's goal was actually to go on living as actively as possible, then doubling the amlodipine was never going to be successful. Treating nonagenarians in cardiogenic shock is unlikely to be successful, but 6 months later, on Christmas Day, I did successfully retrieve somebody with very similar anatomy. So I don't know who is being more realistic. I think it's, I think perhaps both of us were. But so what I would take from this is that if somebody has lifestyle-limiting angina, despite some anti-anginal therapy, so one agent needing GTN to do things, then you decide what you're going to do, having done a coronary angiogram, and you don't worry about what the exercise test shows, and you don't worry about a non-invasive test. You have to decide what you're going to do with a test that tells you, are they a candidate for angioplasty or bypass? It's unlikely in a nonagenarian, but you can have that proper discussion, and you can assess what the risk is, and you can make those decisions together. And if somebody said that actually, I'm going to take my chances, that I do not want you to do an angioplasty, then that becomes very much easier when that's recorded. If somebody comes in, not to put them through a procedure, just to give them a large dose of morphine and say, right, okay, we've made the decision, and we're comfortable with that. There's no uncertainty that we're missing an opportunity to help somebody. Variation value for money. How do we measure quality in an austere health service? And I think the short answer is we're not going to. It's going to be too difficult and too expensive. I'm not sure that it's in politicians' interests to measure quality. But that's perhaps controversial. Okay. The case kind of leads on a little bit to a discussion of complex coronary disease. And what do we do about it? Should patients have coronary bypass surgery, or should they have angioplasty? Should they have major surgery that requires at least an overnight in ITU, probable blood transfusion, recovery from a major wound, cardiopulmonary bypass, with the problems that that gives? Or should they have local anaesthetic, a 2 millimeter incision, a day case procedure? Should they have this? This sternal wound has broken down a bit, or should they have this? And you can see where my biases lie. But I'll go through the data with you. Again, a case history to illustrate the situation. Not all of our patients are really old. The average age of patients that we treat is 60, 62 or something like that. But it happens that I had this case history, and it was an interesting chat. Terrible angina. He was quite posh, and the driveway was quite long, but nevertheless he was quite restricted. He'd had a couple of neurological problems that he'd survived and made an excellent recovery from. Euroscore estimates the surgical risk. It tends to overestimate it, but he was at high surgical risk because of neurological problems in his age, and he and his wife were unwilling to talk to a surgeon. They said no. And so I put a stent and a tight narrowing here in the right coronary artery, in the hope that I wouldn't have to do what we did to the left coronary artery, but that didn't help very much. So he's got a tight narrowing at the ostrum of the left main. He's got significant disease at the distal end of the left main. He's got a very tight bifurcation lesion here in the LAD. If he were younger and hadn't had the stroke, there's no doubt that this is good surgical disease. The surgeon has good big targets to stitch on a new blood supply, and it's not a difficult decision to make. It's a very good treatment. It'll keep people out of trouble for a long time. But because of his other comorbidities, that wasn't something we could do. This is a rotablator, a little diamond drill, 1.5 millimeters in diameter, spinning at 180,000 revs per minute, that pulverizes all of the calcium into tiny fragments that float off down through the circulation and are sequestered in the spleen. And that makes then dilatation a bit more predictable. And we put a couple of big stents in and blew them all up, and everything went really well. And we didn't have any trouble. And he did really well for 5 years. I haven't checked on his vital status for a while. But, he was a perfect advert for what we can do. Is there a prognostic benefit from treating stable angina? And lots of people say there is no prognostic benefit. So let's look at the surgical trials. So bypass surgery is nearly 50 years old. They kind of got it sorted out in the Mayo Clinic in a predictable fashion. In 1967, they published a paper describing outcomes in 198 patients, I think. And it took off because before then, people with really bad angina didn't have any good options at all other than GTN spray. And the studies showing how effective bypass surgery is recruited very gradually over the course of 10 to 12 years. But they were all put together and showed that people treated with medical therapy died sooner than people treated with bypass surgery. And that benefit was maintained for about 10 years. And that's what you expect, that people start getting graft disease after about 10 years, the benefit might disappear. And is this an accurate reflection of the benefit? Well, the patients who got into the surgical trials were really quite heavily selected. So you look at this registry, 16,000 patients screened, 780 randomized. And a lot of people were excluded because they didn't have good disease. They had too severe disease, couldn't have surgery. They had such bad symptoms that they weren't going to be randomized. Or they had left main stem disease, so that excluded all these various other exclusions, people who didn't want to be randomized, and got down to a small number. So it's a very small number, and a lot of these patients who weren't included in the trials, had they been treated medically, would have pushed the medical survival curve to the left, because these would be higher risk patients. So I think it's reasonable to conclude that the surgical trials underestimates the benefit of revascularization. But that's an interpretation rather than what the data shows. This is another slide. I'm not going to talk you through all of it, but if you look at it in detail, patients who were randomized to medicine with left main stem disease did particularly badly. There's a greater benefit the more disease you have, if you've got ischemia on the exercise test, or if you've got LAD disease. So it's been our guide. The surgical trials have been our guide to which patients benefit to the greater extent from revascularization, despite the flaws in the data. And until recently, this was the state of the art. This was the Syntax trial. This was the 1-year survival published in 2009 in the New England Journal, concluding that bypass surgery remains the standard of care for 3-vesicular left main coronary disease because fewer patients came back with major adverse cardiac or cerebrovascular events at 1 year, and that was the end point. This was a much better trial. It looked at all the patients with complex disease and managed to recruit 3/4 of them into the trial. Some patients couldn't be done, but this is much more representative of the population as a whole. Not all of them were randomized, so there were registry arms, PCI for patients who were too frail for bypass, and CABG, and this is 10 years ago, patients who were too complex to have PCI. But they randomized about 900 patients into each arm, so it's a good, big trial. Very representative of what we see, 65-year-old patients, not particularly high surgical risk, about 4% predicted by that model. 2/3 3-vessel disease, 1/3 left main only, nearly 1/4 having chronically occluded vessel, and 3/4 having bifurcation disease. So a good, complex set of coronaries. And when they were treating them with stents, they tried really hard. So the mean length of stent implanted was 86 millimeters. That complex patient that I showed you had about 55 or 60 millimeters. So they treated people aggressively. And after 5 years, there was a trend to improve survival with bypass, but not a particularly strong trend. So a small difference in 1,800 patients. There was a similar trend for more strokes in the bypass group that occurred in the perioperative period. It doesn't tell you anything about the severity of the strokes. There's undoubtedly more myocardial infarctions in these patients who've had stents, and because when you put on a bypass, you protect the patient by bypassing a longer length of disease than would be treated by the stents. And when you put it all together, the numbers were favoured bypass surgery. Last year, 2 further trials, large trials, were published. One in the New England Journal, one in the Lancet, looking at a similar population, left main stem disease plus some other disease, randomized trials, and put together in a meta-analysis. So there's about 4,500 patients in this meta-analysis. So we'll go through this in a wee bit more detail. If you look at it here, death, I think in about 8, maybe 3 years, it's different. But there's no difference in death, and not really an appearance of a trend when you add the other studies. Stroke numerically favours angioplasty, as you would expect, although this effect is diluted by Noble, which had an unexpectedly high rate of strokes, not around about the procedure, but after on, which is difficult to explain. More repeat revascularization and a trend for more myocardial infarction. So you can actually have a good conversation with patients now, saying that there are 2 very good options to treat them, and they're both realistic, and they're both associated with pretty good long-term outcomes, and you're trading off more rapid recovery from angioplasty with a higher risk of coming back into hospital and probably needing another angioplasty. And over the course of the last few years, this is the UK data, the overall rate of treating unprotected left main stem, that means people who've not had bypass surgery before, has gradually increased. And shortly before those trials were published, I found myself doing 2 left main cases in a week, and I thought, where are we with that? And got the data out. So we were very conservative a while ago, but 2015, 2016, we've taken on more left main stem disease. Some of that percentage is slightly enhanced because I've included the protected ones as well. It's unevenly distributed across the consultant body as well. So some people's threshold for doing the more complex cases is lower than others. And that's generally what you would expect. There are some accoutrements as well. The rotablation, not everybody does rotablation. So that there is variation across across the body. So how do these questions map onto complex realism, I've called it? Well, complex disease is high risk. Patients do have high event rates, but potentially high reward. That people who recover from revascularization, and that's the vast majority, do well and have a much better quality of life and reduced risk of running into trouble. You can say that there's no evidence that the randomized trials of angioplasty versus medicine don't show a benefit. But if you accept that surgery has a survival benefit from the trials from the 70s, and there's no difference in survival between angioplasty patients and bypass patients, then you have to assume that for complex patients there's some degree of survival benefit. I don't think that's a sophistication too far. I think variation is inevitable between units, between operators, but shared decision-making via the MDT, which we do to our best abilities without having surgeons actually on site. They do come and visit occasionally. We do contact them with email and national packs, means that cases can be discussed. When people have reviewed decisions made in an MDT with surgeons and interventional cardiologists, you don't always make the same decision. Same patient presented in the same fashion, there's a variation of about 20%. So the key thing is that you're having a good discussion with the patient, that you have worked out what it is that they want. And sometimes patients that I think should really be encouraged towards surgery will just refuse to hear about it. And other times you say, well, it's an option, but I think angioplasty is quite good for you. They've decided that they want surgery, and as long as they're informed, we can step back a step and say, well, that's what's right for them, and that makes decision making much easier than it used to be when we had to try and decide what was correct. The other thing I would say is that patient PCI outcomes are certainly improving with time, that we're taking on more and more complex disease, but we can demonstrate in the randomized trials and in our data that what we could do 10 years ago was much inferior to what we can do now, and it is realistic to offer angioplasty for more complex situations. And I was intrigued to learn that if you say that coronary bypass surgery, if you want an absolute cost, you're looking at 10, 12, 15,000 pounds. But the tariff for CABG in England is slightly less than the estimated cost, and the tariff for PCI is greater, and that's been a decision made in the Department of Health to move away from CABG and to break down the monopolies from some of the large teaching centres and encourage angioplasty to be done closer to the patient. When the civil servants and the politicians are deciding what represents value for money, they're voting with their purses. Right. Okay, we're still on time. So you've got maybe 10 minutes of my interpretation of my own personal subspecialty interest, which is opening chronic occlusions. Coronary circulation develops collaterals. Variably, over a certain length of time, maybe 2 weeks. So this patient, there's a catheter here in their left coronary artery, and they've got this large collateral that's opened up, arterialized, and is filling up the right coronary artery. The right coronary artery is occluded just beyond this branch here, and there's a chronically occluded segment between here and here. But the chronic occlusion has developed with sufficient time to allow the collaterals to preserve inferior wall function. So that patient has angina. Tunneling through chronically occluded vessels is technically much more challenging than just wiggling a wire down a patent vessel. But Japanese operators, probably 15, 20 years ago, developed techniques that make it much more predictable. And that's apparently in Japan it's a major taboo over having a scar on the chest, because apparently the soul escapes through the chest. So coronary artery bypass graft surgery was less favoured, was culturally less favoured, and the cardiologists developed complex skills. And essentially, what's difficult about chronically occluded vessels is that getting back into the downstream lumen is difficult. That you can perhaps manipulate a stiff or slippery wire along the vessel, but it tends to get displaced by calcified old atheroma in the occluded segment, and may perforate or may just work its way along in the architecture, and difficult to turn back into the vessel. This illustrates that in a different way, but you can choose to dissect along the subintimal space, so outside the atheroma, but in the elastic tissue of the artery, using blunt dissection. So you get, rather than using the point of a wire, which is sharp and may penetrate, you use the bended wire, which forms like an umbrella handle. So I don't know if you've ever prepared chicken by putting herbs under the breast skin and butter. If you want to take it off, you don't use a knife to try and cut the skin off. You use your blunt finger and go along a tissue plate. So it's the same principle. And the other advantage is if you've got a long occlusion, your eye tends to draw a straight line between the top bit and the bottom bit, but there may well be bends there, and if you put a sharp penetrating wire in a straight line, then you're going to come outside the vessel, cause a perforation. And there are some techniques that I'll show you. This is called antegrade dissection reentry. So this patient has an occlusion of the left anterior descending that's filled up through these bridging collaterals here. And there was no other collateral supply, but it's quite a good big vessel. And it's difficult to see the tip of the wire, but we've folded the tip of the wire, and that's dissected down along through the side of the vessel, and the equipment's overlapping the vessel, not in the lumen. And this is a special balloon called a stingray, like a flatfish, that doesn't blow up like a balloon, but blows up the wings, which hold the vessel, that hold the balloon in place over the top of the vessel. And there's a hole from the lumen, one going up and one going down. So when you see it perpendicular, you can work out whether you want to go up or down. And you take your sharp, stiff wire, and you find the hole that goes down, and you push gently, and it pops forward into the lumen. And then you can put some stents in, and that patient didn't need to have a bypass. The other thing that you can do is use the collaterals as a method of access. So this patient's got an occluded right coronary artery, but we're starting from the left coronary artery. We're coming down the septal with a wire that's sitting in the distal right coronary artery, and we've got a microcatheter to follow it round. In this sort of case, we've got the microcatheter come all the way around through the right coronary artery, out into the aorta, but we couldn't get the wire into the guide, so we've used a snare here. So the wire is actually coming out through the right coronary artery, up around the aorta, into the snare, and we've grabbed it so we can pull it into this other guide and get the wire out the other side. So we've got a wire going up from the wrist, through one coronary artery, through the heart, up through the blockage, out the other coronary artery, and out the leg, and then we can put the stents in, out the leg. So that's a very effective way to treat people. But it's expensive. All of these extra accoutrements mean that angioplasty for chronic occlusion is at least 5 times and perhaps 10 times more expensive than standard angioplasty. So managers have their eye on this sort of procedure. Is it value for money? And this trial, a colleague presented it at the Scottish Cardiac Society in Glasgow, has led to some significant questions about should there be any chronic occlusion angioplasty done in Glasgow. So this isn't the latest word, but this trial has been presented in an abstract. They wanted to recruit 1,500 patients, but like many of these trials, it was slow to recruit. They recruited patients with silent ischemia, that's the first angina and post-MI, and showed no benefit in symptoms and no benefit in prognosis. It was a complex trial, like 400 allocated to what they called optimal medical therapy, but a significant number were treated with angioplasty anyway, so it's not just tablets. Substantial numbers didn't have complete data, and the long-term follow-up is relatively incomplete. There was a numerical benefit in terms of all-cause mortality, but it didn't achieve statistical significance. But is this trial representative of the patients that we treat? So here's the baseline characteristics from Decision CTO, and here's the baseline statistics from the UK Hybrid Group, which is an informal organisation, but collects data in detail on CTO patients. Each of these centres recruited up to 10 patients per year. Now you've got to do about 50 to get good at this. So all of these centres are doing at least 50, and some doing a lot more. So of the 10 patients that they recruited, that's not going to be the 10 most symptomatic patients, 10 most ischemic patients. Age was younger than the UK population. The previous MI was infrequent, and previous bypass was very infrequent, whereas previous MI in the UK population was 50%, and the previous CABG was a fifth of patients. So if you're looking at the patients that get treated again in the real world, they're much more complex, much more symptomatic, much more, this is really the only option. They've failed medical therapy than this selection of patients who haven't clearly failed medical therapy. And the other advantage, as well as treating patients with symptomatic angina, here's an illustrative case of the advantage of having all techniques available. This patient had bypass surgery 20 years ago and has developed this absolutely massive aneurysm on their vein graft. So this catheter is in the native right coronary artery, which is occluded here, and has probably been occluded for 20 years. This catheter is in the graft, which should be about 5 millimeters across. This aneurysm is about 6 centimeters across. And he'd presented earlier in the week with chest pain that wasn't really like his angina, and it may well be that chest pain was a threatened rupture that was luckily enough to be contained by the tissue. This next picture shows it perhaps more clearly. It's absolutely enormous. He's still got patent lima, he's still got another patent graft, so redo surgery is going to carry a mortality rate of at least 7% from going back in through the sternum when you've got the vital blood supply running through scar tissue immediately under the sternum. And the surgeon that we presented it to said it's technically very difficult to close it off as well. We do have covered stents, but covered stents don't always seem to be able to occlude it. They're difficult to expand, difficult to get opposed to truly seal them off. In this sort of diseased graft, there's another small pseudoaneurysm here. It may be that recurrence would be extremely high. Another thing about putting a covered stent into a 20-year-old graft is you can release a lot of debris from the graft and cause a big heart attack. So you may find that you can block it off, but you release so much debris that the patient has a large myocardial infarction. So we were able to use the graft to come to the downstream vessel, get our equipment retrograde. There was a tight lesion here, which meant that he got quite ischemic, but managed to put up with us working for a while. Here's the microcatheter here, through the occluded segment, forming a knuckle that tried to go up a side branch, but came back a little bit with the microcatheter, fold the wire over, and then the knuckle just advances in the tissue up to this guide extension that's sitting there. So we know that we're in the right place. We then blow up a balloon to create the dissection plane between the adventitia of the artery and the lumen. And then we can take a little while, and we can find those dissection planes with our wire. We can thread our way through them and out of the subintimal space in the adventitia, back into the lumen, and where this guide extension is waiting to receive the wire. And once it gets in there, which is just about to happen, I missed again. It looks like an open goal, but it's still in the subintimal tissue. Back a bit, find the way, and the wire goes into the guide, and then we can treat the patient successfully. So we put a series of stents in the native vessel, and then we could block off the graft distally with this little graft occluder with help from Interventional Radiology, and they helped us with this large covered stent, which then sealed off the graft. There's a little bit of flow trying to get around the side of the covered stent. You can see up here and down here, but we didn't need to jeopardize all of the inferior wall of the heart. This is going to clot up. This aneurysm should clot up. And 2 hours later, the patient was sitting up as though nothing had happened. So, realistic CTO PCI, it's best for treating symptoms. Or if you've got a young person who's come in with an ACS and there's another CTO, then there may well be benefit to treating it. They may have better survival, because if you have a heart attack and you've got a CTO, you do much worse than if you do not. You do have to have all the techniques available. Innovation mandates variation. So for a long time in Scotland, you could get this done in 2 centres, but there's now at least one operator taking on these complex cases in every centre. But innovation mandates high quality data, and if the government are not going to pay for it, then we have to do it ourselves. And I entered all the data for the Tayside patients, followed them up, and that was quite time consuming. So finally, the last bit that I was going to say, from the whole point of putting the thing in for the Cullen Award was to acknowledge that it's a team effort. And here's various members of the cath lab and CCU staff reminding the photographer what organ that they look after. Okay, thank you very much for the select audience. I hope you found that interesting, and if you've got some questions, now's the time. Yeah, so if anybody ever looks at the recording of this, I'll repeat the question. Is there a specific time frame for repeat revascularization? There's two processes requiring repeat revascularization. There's stent restenosis, which with the modern stents we very rarely see. So about 3%. it's hard to think back to patients coming in with restenosis. If that happens, it happens within the first 6 months to a year. And then if they don't have restenosis or stent thrombosis, which is about 1%, they get a blood clot in the stent, then they have an annual risk of about 5% of recurrent myocardial infarction that's likely to lead to further PCI. A small number, if they have restenosis or changed anatomy, would then require bypass surgery. I think that's right. I think there are patients who would potentially benefit substantially from invasive approach who don't get it out of perception that they're too old. But I wouldn't advocate somebody going through it who's significantly confused. You know, even an angioplasty is a bit of an ordeal. We've got a patient who was early 80s, living independently despite dementia, and she had a straightforward heart attack. So, you know, it's not a big deal to do an angioplasty, but she remained hemodynamically very unstable and needed an adrenaline infusion because she was getting profound bradycardia. And so we put a pacemaker in at the weekend, which was slightly unorthodox, and she survived her heart attack, but she's had a huge, she's gone from independently functional to needing a nursing home, and that's not a great outcome either. But it was certainly realistic to offer her primary angioplasty, because if she goes home on day 3, she'll be fine, and it wasn't implausible that actually she would bounce back and have good survival. But you know, so I think it's all about the level of functioning and how big a hit they can tolerate. And it's my practice not to refer people for certainly for CABG once they pass the threshold of 80, just because I don't think the incremental benefit, even in complex cases, is worth it. I don't think that's very different to most of my colleagues. Yeah.
Can you see a situation where everyone might be used as
So I had a call from Roxburgh House a few years ago about a young man with metastatic cancer who was having a STEMI, and I had that very discussion with the palliative consultant looking after him, and in the end we decided not to go for PCI, and he got high dose opiates, but he had I think he was final stages of palliative care, but certainly I was open to the idea that we could do it and send him back. The difficulty with angioplasty is that it does mandate dual antiplatelet therapy for at least a month, even with the most modern, fastest healing stents. And if you've got a lot of other comorbidities, then you may not absorb it, or you may. So that's still But otherwise, yeah, it's worth having the discussion about almost everybody. Okay. Well, thanks very much for attending.